Hi, everyone. Welcome. My name is Hector Del Castillo, Chief Product Officer at Bold PM, and I'd like to welcome all of you to tonight's meetup. The topic for today is COVID-19 and the search for the silver linings. And tonight's speaker is Ajay Gupta, who is CEO of HSR and Health. And here's a look at his discussion and demo of a digital platform that he has built to measure pandemic response across the US by different organizations that are tracking this, organizations like WHO and FEMA. Thanks so much. Enjoy tonight's talk.
May be able to use our tech, fantastic. We may be able to use our tech to keep our rate of pandemics below the 1 every 20 years, or maybe even establish a new long-term rate. Let's see if we can do that. So I'm going to talk about the search for the silver lining. And this is because, like many people, I am an archaeologist at heart after watching these movies. And we are going to delve into the mystery of COVID-19 and see what positives may be coming out of it. Just a little bit about me. All of these things are accurate. The things that I'm proud of is that I have an opportunity to chair the health domain at the Open Geospatial Consortium. We're a geohealth company, a geospatial technology company that focuses on the healthcare space. The Open Geospatial Consortium is really the industry standard setting body for data sharing. It's really the trade association for our field. And I have the privilege for the past couple of years of chairing their domain working group in our field of health. I work with HIMSS, which is a trade association for health IT firms, and I've served on the Social Determinants of Health Task Force, and I've also had opportunities to serve on the Education Committee for our national annual event. I also love karaoke, as anybody on the call who knows me can attest. So Hector didn't mention it, but before the end of the session, we'll all do a song. We'll pick a song. Please feel free to post that in the chat, which song you want to do. So just briefly about the company as to how we came to being a company that can work on a pandemic. We got our start looking at what we now call social determinants of health, by analyzing that data, and we take a very broad view of that and reporting that to health systems and community service organizations. And then, 2019, it's now more than last year, we started reporting on that to FEMA and others in a disaster context, reporting to them how social determinants, everything from age to population to environmental factors to education levels, interplay with health outcomes and healthcare costs in disaster scenarios, so that FEMA and other emergency response personnel can prepare to deliver medical and life-saving health and medical during disaster response. That was a big pivot for us, because what we had learned from FEMA and the public health force is that they didn't know the health needs until they got on ground after the disaster had passed. So it was a delay in providing care. We were able to build that, essentially a disaster support system for them, in 2019 before the pandemic hit. And then, of course, in 2020, when the pandemic hit, we were positioned to pivot to develop solutions that I'll talk about that help global public health organizations like the World Health Organization, national CDCs, and other industries assess the risk to the pandemic. So today, are there silver linings to a COVID-19 pandemic? I'm going to talk about several, and I'm sure there's going to be many others that we can have some time to talk about as well, that have a role to play both in our lives and even in our health outcomes. For instance, one area that I'm sure we're all familiar with is that we are not really commuting to work the same way as we were before. Now we're either working from home, or if we still have to drive, at least initially, the road traffic had gone down so much that commutes weren't as big a problem. That's definitely something that we can consider to be a benefit, right? At least in some way. There may be some drawbacks to staying at home, but not being in traffic is a benefit. What I'm going to talk about are GIS systems, how we've been able to advance the state of GIS during the course of the pandemic, as well as increase its awareness and deployment in public health and health systems overall. Also, a component of that is that we were able to leverage more information in healthcare than in the past. I'll talk about that. We also have pushed the bounds of predictive analytics. and have addressed health equity concerns. One additional benefit that maybe I won't talk about so much because it's in the pharmaceutical space is not the invention, but really the broad deployment of mRNA vaccine platform for the delivery of vaccines, right? They are different than the typical vaccines that we're used to, like MMR, measles, mumps, rubella. It's a different platform, and maybe in the long run, a better platform for vaccine delivery. And this was an opportunity for this to shine. Okay, so these are some of the work that we've done and we feel are an advantage. One of the roles that GIS has, I'll quickly go through these slides and get to the demo, but one role of GIS is that it places lots of layers of data on a map for quick consumption and immediate action. So when you're doing a pandemic response, one thing you have to have is both the national global view of how risks of transmission are happening, as well as a very local view, right down to neighborhoods and census tract levels as to where people are getting sick and where they need help. You need the global view because that is the global transmission vectors that have to be interrupted. Those are things like diverting flights or canceling flights and closing borders. And the local view is where are the people who are most at risk of mortality or most at risk of viral transmission, and how can I protect them? We are able to do that with GIS systems in a way that you can't do with others. And this does involve putting lots of different data sets together. Our platform is really the largest geocoded health and social platform in the world, because we do bring together platforms from all walks of life. So this allows us, and now that we can do it, this allows us to contribute to the world, a greater understanding of where diseases can come from so that we can intercede on those diseases in advance. So most pandemics come from really zoonotic spillover events. These are essentially animal diseases that somehow jump to a human population, right? These zoonotic spillover events can be tracked if we have the right kinds of data to identify it, both in terms of what's happening in the animal kingdom and how those diseases manifest in the first few humans that catch them. We can also identify specific locations of disease spread. So for instance, not every location, not every restaurant, for example, has the same level of risk of disease transmission. Some restaurants are different sizes. They have more people or less people. They have more spacing between buildings or tables and less. They have different ventilation. They're all different, right? And of course, some restaurants have a fast pace of service and some a slow pace of service. All of that contributes to the risk of disease transmission in a restaurant. What we have been able to do is identify what those factors are that contribute to the risk of disease transmission and inform that by facility, by region. So in a future pandemic, rather than broad-based lockdowns, you can target lockdowns. You can maybe lock down those buildings or those businesses that are the greatest risk of transmitting disease amongst the population. Or we can identify what factors of those buildings contribute to that disease risk and address them. It could be, in some cases, that upgrading an HVAC system in a facility will completely change the risk profile. And that's something that we can do. There's a cost associated with upgrading an HVAC facility, but it's a far lesser cost than dealing with treating pandemic patients in a hospital. We've also been able to use predictive analytics in healthcare. Now, of course, AI is not new. And this entire series that Hector has set up talks about all the great things that machine learning and artificial intelligence and data science can do. But in healthcare, we have really pushed the bounds of the machine learning, deep learning, AI models that have been in place. Our firm alone, even though we conduct extensive analysis and research into existing models, everything that we identify for use, we adapt substantially enough to really call it a new model. For instance, early on in the pandemic, we were able to identify the exact number and range of ventilators needed to treat patients and which locations to place those ventilators. And we were able to work with a number of states, those who had too many, those who had too few, to share and place ventilators as needed so that the supply met patient demand throughout the pandemic. And this was the result of new models of assessing transmission risk against mortality risk for those patients that are at highest risk with underlying causes. We were able to do the same with PPE, and I'll talk a little bit about that when we get to the demo, and the same with vaccine needs. Essentially able to track vaccine deployment against need by population, by underlying health condition, by occupation, because we did want physicians and clinical care providers to go first. And just as point of thought, we talked about this earlier, we've had about 157 million doses delivered across the country. It's about 1/6 of the country has both fully vaccinated and about 1/3 has one vaccination, which helps. Even the first dose helps. We're on the way. I think we may achieve a good level of immunity, and I agree with the notion that those who aren't getting it don't have faith in it. We'll need to do something spectacular to change their minds. Secondary market impacts. We've done a lot. This goes to showing the impact health and health disasters has on broader markets. So we first started looking at the funeral home market, right? If there's going to be a pandemic, that's likely to mean that the morgue carrying capacity in hospitals is going to be exceeded, because hospitals don't size their morgue for pandemic level of fatalities. And that means that their local funeral home capacity will be exceeded. So we developed a system to help hospitals identify funeral homes outside of the high impacted area that they could call upon for emergency service when the local homes and crematoriums are in rush. Now, you may not think that this would happen, right? How could, that may not be an obvious eventuality of a pandemic, but it is, and it was. And this system to identify those that are not in rush that could help out hard hit areas came in hand in a lot of places. We've also been more recently able to, and this is sort of how we start looking for post-pandemic, right? We know that the pandemic has led to shifts in consumer behavior, and to accommodate that, businesses have shifted. Some have unfortunately fired employees and closed down. Some have actually expanded. So for instance, the delivery businesses, everything from Amazon to Uber Eats, have expanded operations because more people are ordering online and taking deliveries. And there's also more people doing curbside pickup. But a lot of that is even being done by what we call in the field couriers and messengers businesses. So we can track the increase in courier and messenger businesses against the increase or decrease in risk. These curves represent the COVID-19 risk for various states, an East Coast state, a Midwest, and a West Coast state, and can track employment against risk to see how that has been shifted. And now we can see in a post-pandemic world, or at least post today, whether we're post-pandemic or not, we can, and given that we know the transmission risk and the case count risk of COVID going forward, we can track employment in those fields to assess whether employment remains high, meaning that change in consumer behavior is permanent, whether employment goes down, meaning that consumer behavior change was temporary and people are going back to their old habits, or somewhere in the middle, which means that some change is permanent and therefore future economic activity in that industry is set to rise. And that can allow those who invest in the businesses, right, the economic markets, to recognize and predict future economic value based on health considerations. We've done that with jobs as well. Just by county to compare the impact of the pandemic across county lines, which works well in the United States as we track economic data at several administrative levels, and can work globally at a national level as well. We've developed a flight risk index that helps airlines assess the risk of disease transmission in an aircraft so they can mitigate that risk and use that action to win customer confidence. So you may have heard of several airlines who have announced changes in their operating practices. Some, for instance, are blocking a middle seat. Blocking a middle seat increases the space between passengers and reduces the risk of disease transmission. That kind of activity can, when responsive to consumer concerns over disease transmission, can be helpful. And talking about schools, and I certainly am one that believes that kids need to learn, they need to get back to learning, and there are risks of being in a classroom with other kids. There are risks to them, to the teachers, to the parents, because kids can be a vector of disease contagion. But eventually we got to get back to it. So our solution provides a mechanism that allows kids in a classroom, and this is a particular classroom, this classroom actually exists in our local area, that we can identify the risk of disease transmission in that classroom in a way that allows us to assess the changes if you put barriers, if you put masks on the kids, or if you do other situations to change the classroom layout so that we can find a way to get kids in the classroom in a safe way for all involved. We can do the same at work, and we have modeled this on the workplace from, I think, a lot of people's favorite show, The Office. So our team's favorite show is The Office. So we took the office layout of Dunder Mifflin and assessed the risk of disease transmission there to everybody so that we can help assess how to bring people back into the workplace safely so they can keep entertaining us. And yes, we will find our silver lining. I'm going to go to a demo now. And while I switch, feel free to let me know if there are any questions that I can respond to.
I'm entering the chat right now, and I don't see. I see one question. I don't know if you can get to it right now or defer, but
shoot.
It says, what indicators are you tracking for populations based on longitudinal evaluation of variants and populations that have received complete vaccination?
Oh, it's a great question. We are doing some of that research right now. So we are tracking a great deal of the first part of your question was on what we're tracking for the pandemic, right? We are tracking a great deal.
Like basically by location, the variants and the highest concentration of the variants, but also vaccination of the population.
So we are tracking the variants, the primary UK variant and the secondary UK variant that is maybe not risen to that level yet. We're tracking the South African variant, we're tracking the Brazilian variant, and we are keeping our eye on 7 variants that are homegrown in the United States. We are tracking to the extent that serological testing is identifying COVID cases by variant, which many states are starting to do and starting to report. So we are tracking case counts, deaths, and vaccinations of populations against the specific variants in those cases. Obviously, the goal is to assess how the vaccinations are holding up against variants. So far, the news is promising that the vaccinated are doing okay. Now, that is a very fresh vaccine, right? Anybody vaccinated now, even on April Fool's Day, has only been vaccinated for a month or 2 or 3 months at the most. That's very fresh. But so far, the results do look promising for the current batch. Really, the race that is on is, can people get vaccinated fast enough so that there is less opportunity for the current COVID virus to mutate into new variants? If that happens, we should be okay. Now, if we have large percentages of the population that don't take the vaccine and are essentially unprotected one way or another against the vaccine, that makes for a fertile ground for COVID-19 to mutate. One of the studies that we're doing right now, in fact, is led by the head of our public health team, is to assess the risk of those populations that are choosing not to get vaccinated, which by and large, I know Nancy mentioned 2 of her kids have chosen not to get vaccinated, but by and large, those populations are also the socially, economically disadvantaged, right? For various reasons. Access is one reason, but distrust of the health system is the primary reason, right? That's why you said, Hector, we need a public campaign, a PR campaign. That distrust could mean that if that population doesn't get vaccinated at high enough numbers, they may themselves cause new variants, or not that they cause the variant, COVID causes the variant, but the variant could be born in those populations, not just hurting their own health now, but hurting or making them susceptible to COVID and its descendant variants generations to come. Essentially, we are tracking to see if health inequity can be inherited. And if it can be inherited, then we may be able to stop that trend by convincing everyone to get vaccinated. That is a great question, and that is something that is a current area of research. So this is our platform. It is a geospatial Spatial data infrastructure, that's simply a fancy way to say it's a very large database of geocoded data. That means data for which we know where that data takes place. So if you know the temperature is 62 degrees, we could tell you where it's 62 degrees versus another location where the temperature may be 92 degrees. That kind of data is what we have. And we use this data along with a machine learning AI engine and residing on a blockchain to do our COVID analytics. So we've done work in Africa and around the world, as well as in the United States. I'll go to the US hub first. Maybe later we could see a little bit of the Africa hub if we have time. I know we're coming towards the end. But we've done a lot of work in Africa for tracking COVID at the state level, as well as at the county level. And that's because this is something we've learned new in this pandemic, that each layer, each of our governmental layers, federal, state, county, has a role to play in health emergency response. That is new. That has not been the model in the past. But here, decisions on lockdowns and really the decisions on reopening were pushed down one level at a time. Federal to the states, states to counties. To some extent, this is an opportunity. And that's because we know that no condition, whether it's temperature, weather, storm, health, is that uniformly distributed. So somebody sitting in Washington, D.C., when they get a view of COVID, that view of any disease is probably wildly different than Florida and California and Maine, just because the environments and the populations and the geography are all different. So it makes sense to allow lower levels who are closer to the ground to make their own decisions. So we can do that. One of the things that we've done and have shared with task forces, and that task forces and health systems have used this to do resourcing within their health systems. So this is a map. I'm going to try to clear the screen of the pictures. This is a map that tracks predicted flu as well as actual flu, along with predicted COVID and actual COVID hospitalizations over time, and then allows us to make predictions of COVID over time into the future. So as we see here now, it does look like at this inflection point, and this is sort of where we were when this demo was created. I believe that is mid-March, that it looked like we were ready to see a little bit of a bump, but then a good decline. Now, onto this, there are a number of factors that weigh in. The rate of the population that is getting vaccinated, the rate of the population that is staying quarantined. If you quarantine and you don't meet other people, you substantially reduce the likelihood of a human-to-human transmitted disease, as well as the rate of penetration of variants. So absent any future variant of COVID-19 that may be more contagious, it does look like, at least for the state of Maryland, that we are getting past COVID, at least for this current wave. That's very good news. This future information, though, allows health systems statewide to plan their resourcing going forward. One of the things that we've heard, I'm sure you've all seen, that our clinical team early on, especially in the hard-hit areas early on, Seattle, New York, were really burning out, right? They were working all day, every day. And as they became sick, those remaining had to pick up the load, and they were seeing large numbers of patients. That is not sustainable. Having visibility into future case counts allows hospitals, to the extent that they can, to platoon nurses and give people much needed time off as and when necessary. It also allows them to make sure they have the right amount of PPE, that kind of thing, for the patient population. Now, this is something that we update on a daily basis and communicate to state level coronavirus task forces. We also do this at the county level and share with the county level task forces. Of course, in Maryland, it looks quite similar. Now, that's not always the case. There are other counties where that may be quite different. You see, Carroll County, for instance, which is on the eastern part of Maryland, they seem to be having a little bit of a different response. They have some static periods between their overall decline. But Maryland overall has done a fairly good job, although at pretty aggressive lockdown steps, to manage COVID. We've done this throughout the country by FEMA region, and each FEMA region has its own set of states. Paul, where's FEMA Region 6?
You have to change the state.
Okay.
What? Oh, it's because you have to change the count. Yeah, I still need to fix that filter.
Oh, no, I'm sorry. This is not a state one. This is at the county level. So
yeah.
Go to the state. So the FEMA regions, we've done this for the FEMA region, and that's because obviously FEMA is, one of the partners we work with closely. And so we can look at any state in the country and then down to any county in the country and do an assessment of current and future flu and COVID hospitalizations. Now, one thing you'll note that we have done, and this is something that we should be very carefully monitoring, because of all of the measures we've taken to fight COVID, we seem to have stopped everything related to the seasonal flu. Now, that could be because the seasonal flu happened to be weaker this year. It could be because our testing for the flu has gone down. It could be because the population that typically catches the flu is not mobile. But there's got to be a reason, and that reason is would be very instructive in future public health scenarios. That, though, is a silver lining. We beat the flu this year for the first time really ever. Somebody mentioned that we're tracking a question on variants, right? And Paul will help me with this because he's been doing a great deal of this research into variants. We are tracking COVID cases by variant for those states that are reporting it. Now, most states, jump in, Paul, are reporting variants, COVID cases by variants for only those most critical and those variants of concern, right? Mm-hmm. The B117 from the UK, P1 from Brazil, the South African variant, but there are, as I mentioned, possibly 7 variants in the United States that we're looking at to see how novel they may be. One thing that we don't want to forget is that COVID-19 was a novel disease, meaning when it started, we hadn't seen it before. Not our scientists, not our bodies. So there was no knowledge, not any real knowledge, and there was limited previous experience on how to deal with it when it got to the immune system. The risk of a variant is primarily that the change could be so much that, again, when the immune system encounters a variant, it doesn't know what to do. So it starts from ground zero. In that scenario, that's potentially a risk. So far, none of the US variants have confirmed that behavior, but we continue to monitor that. But what this allows you to do is go from state to state and just see, let's just look at DC because we're focused in DC, and see what kind of variant exposure we have. So this is a pretty big and consistent block, right? Active cases over 30 days per 100,000 population. This is a 533.7 active cases for over 30 days. It's pretty bad. Now, that's not good, right? I mean, we can't sugarcoat that enough. We definitely want to get all of these high risk areas down. At least one silver lining we can take out of this, and I'm going to try to stick with that, is that as these long-term cases remain in an environment where our mobility is going back up because we're opening up businesses, opening up indoor dining and that kind of thing, it's good that these numbers aren't exploding. They're remaining relatively stable. That implies that the vaccinated are holding against the disease. And that also implies that new populations aren't necessarily filling up the hospitals. Public health professionals at state levels, in this case DC, can use that when making decisions about next steps of reopening. Hector, any other questions coming in?
I'm looking. We have lots of comments, but no questions. So you can proceed unless you're ready for Q&A.
Well, I'm always ready for Q&A. One of the things I'll just mention, then we'll just go into Q&A, is that We knew early on two things from the pandemic, right? And this are both qualify as silver linings. One, we learned that our supply chains have a lot of global components, and that's a risk, right? It's not necessarily a risk that other countries make so much of the things we use. The risk is that we don't necessarily have the capacity to surge the production of those things, especially if those things are important, like the personal protective equipment used in the health setting. One of the things that we did early on, because there was so much interest in establishing a US manufacturing and production capability of critical supply chains, was began to track unemployment by state, shown here for Florida, and show where and by which field unemployment was high, because that would be then a potentially ripe employment base for establishing a PPE production capacity. And by also tracking PPE need by area, we could say not just these are the potential users of PPE, but also match the user population with a potential new manufacturing capacity. So you could have not just-in-time production as well as local production, reducing the burden of delivery and transportation. So this could be used and was used by many states around the country to establish emergency PPE production facilities in those areas where some people had been, let go of work. That was helpful in restoring employment levels and helpful in helping to build some local personal protective equipment.
Yeah, we do have a question, a couple of questions, but the first one is there a correlation between like testing and how often it's done and versus vaccination but for a specific location?
So there really isn't a correlation between testing, how often testing is done, and vaccination. Testing for the presence of a disease is a point-in-time test, meaning that a person can take a test at 6:17 on April 1st and get a negative result. They are not infected. But they can go outside, meet somebody who is infected, or do something else and become infected right away, right? So that is just an unfortunate reality of medical testing and not necessarily related to vaccinations. In this case, we took the approach that we were looking not just to have a vaccine, but a complete eradication type of vaccine, meaning we want to give it to the entire population. We want to achieve herd immunity. We want to consider it like the MMR vaccine or the smallpox vaccine that really did go a long way in eradicating disease. I mean, we could consider measles eradicated if there were no anti-vaxxers in the United States, right? We attempted to do that here, and so we're rolling it out to everyone. Now, there has been some interest in maintaining testing, even for the vaccinated, really to assess a number of things related to whether they're building antibodies and whether they are remaining immune from COVID and its variant forms. Remember, these vaccines were built very quickly. That's just simply a reality of an emergency scenario. And as they were built quickly, there wasn't the necessary time to assess their efficacy for all forms of COVID going forward. And there also really wasn't the necessary time to do a full-fledged clinical trial. These are not approved vaccines. They are emergency use vaccines, so there may be some gaps. And we do know that Pfizer and Moderna, for instance, but also AstraZeneca and Johnson & Johnson and all of the other pharmaceuticals are continuing to work on the base formula as well as the formulation, as well as the delivery mechanisms for these vaccines. Some are starting to put it into a pill form, for instance.
Got it. Yeah, thanks for that. A second question that we have is, can you talk about how effectiveness of a vaccine is measured? Did that change because of emergency
Yes.
rules, or is it the same as before?
No, it did change. And so that's a good point. And as I mentioned, these are not approved vaccines. They are emergency use. The FDA was very forthright in saying, we're going to make this available because the pandemic is a pandemic, it's an emergency, and we are taking the very best science that's available, but these are not stage 3 clinical trial vetted vaccines. So we should anticipate a higher level of side effects. We should anticipate potentially a lower level of efficacy. And we should expect that these pharmaceuticals, as I mentioned, they're trying to do so now, will continue to refine the vaccine over time until they, quote, get it right. Right. That's not to say they're wrong. I think the death rate associated with these vaccines is low. I think the death rate for these vaccines is actually trending to be lower than the death rate of the smallpox vaccine. And we all know that everybody wanted to get the smallpox vaccine because that disease will kill you fast and painfully. Right. There weren't a lot of anti-vaxxers around at that time.
Great. Thank you so much. I don't see any other questions right now, but we actually would like to get into Q&A, and I'd like to ask the audience, if you have any questions, either you can type them into the chat, or we can also, you can actually unmute yourself and then ask the question, but just make sure that you let me know, and we can actually just spend the rest of the next few minutes. We got about 10 minutes left or so before 6:30. So I just wanted to invite anyone to type in your question or just unmute yourself and ask the question. And then Ajay, what I wanted to ask you, can you share your contact information via the chat, so in case people have
Absolutely.
any questions or any additional things they want to follow up with you offline? Would be great if you can share your contact information via the chat with everyone.
Would love to. And Paul, go ahead and post my email address on the chat. I don't know if I have access to it right now, because I'm sharing my screen. But yeah, my email address is agupta@hsr.health. I would love to talk with everybody. And I would love to see if there's any questions. If you don't have any questions for me, I've got a few questions for you.
And right now, I don't see any more.
All right.
Well, there's one says, basically when it comes to policy issues, right? Our public officials or elected officials that you're working with,
Mm-hmm.
considering the issue of public health emergency, when does it stop? When do we go back to the way it was before, or is it going to be a next normal?
Yeah, yes, of course they are. And I do think it's going to be a next normal. And I actually would say that that's a little bit of a silver lining, right? So I think we started today talking about our interaction with other people we don't know. And hey, that could be a cause for disease transmission, right? And in a way that we never really thought about that before, right? We never really thought about riding on public transportation, meaning that we're exposed to strangers whom we don't know. Right? Whether it's a school bus or a metro system or an aircraft, right? That we're flying from Dulles to Dallas in our example. But that's a very real consideration. If you are in a space, enclosed space with someone you don't know, you are exposing yourself to their condition, right? And we know now that we have a conscious public understanding of the fact that people could be asymptomatic, they may not know their condition. Mm-hmm. So the fact that we are now aware of it, I would add, here's one thing that we should consider. Exposure to disease is not infection when we have an immune system that intercepts that exposure. So we can all focus on strengthening our immune system. And there are well-known ways of doing that. Get the right sleep, eat well, reduce stress, be happy, laugh, you'll build your immune system. And the exposure is not infection. Infection is not death, right? We have healthcare. We have the capacity to heal. And not everybody, in fact, about 85% of all people globally recover from COVID-19 without any medical intervention at all.
Yep. So, and I see, Nancy, do you have a question? I wasn't really sure if you have a question. I wanted to make sure at least I would ask, because I see that you muted yourself.
Yeah, my question about efficacy, I'm an engineer as well, so I still don't understand when they say something's 80% effective at preventing COVID. Was that tested against, so out of 100 people, does that mean 20% will get it just in the general population? Or were those 100 people actually exposed to COVID and only 20 got it? Or are those 100 people still wearing masks and still socially distancing and 20 people still got it?
So no, that percentage would not take into account other countermeasures and mitigations that may be in place. So if you're talking about, and I think you're, Valerie, I'll get to your question too, but Nancy, if you're talking about a vaccine at 80% effectiveness, that means what that would imply is if we consider the smallpox vaccine as fully having eradicated smallpox, right? It wasn't, but let's assume that's 100%. Then an 80% vaccine would have an 80% chance of reducing cases of mild symptoms and reducing cases of critical symptoms, lessening the impact of such, right? That's not to say that out of 100 people who are exposed, and that percentage would be of exposed population, that only 20 will get it. It doesn't necessarily have to be that 20 people will get it, but the vaccine will improve the efficacy or the resistance by a factor of 80% versus a factor of 100%. So for all people, as long as the vaccine is safe, it's helpful to get. And Valerie, your question, I wonder if we are testing at a level necessary to determine this. I think yes, most people now are just focused on getting the vaccine. I think that from the population and from public health outreach. And I would agree with that, right? If we're going for, Valerie, an eradication level exposure, herd immunity, let's just give everybody the vaccine. We don't need to worry about testing. Although that means, and I think the core of your question is, that means some very healthy people who had no risk to COVID will still get the vaccine. That's okay. Let's just give it to everybody. We've already sort of ordered it. We've built it. We are, AstraZeneca and all of the rest are manufacturing these vaccines to accommodate the entire population. Let's do that. Now, a silver lining could be digging into your question a little bit, right? A silver lining could be, what if we don't have to do that every time we encounter a new disease? What if we only give the treatment to those who are most at risk, considering those who are lightly at risk are going to be okay without an expensive vaccine treatment? That is a fair question and potentially a learning for, God forbid, a future vaccine.
Mm-hmm. Right. And I just wonder if, for example, mRNA basically establishes, is a gene therapy,
right?
Right. Where we have others like Johnson & Johnson, which uses a viral vector. And there are others that use protein or inactivated virus,
right,
not being used in the US right now.
Yep.
Just thinking about just sort of that overlap and what potentially becomes sort of that real level of herd immunity, even against variants.
Yeah, I think, Val, my opinion on that, and I think this is all in the realm of opinion, right? Because this is novel, so we don't have science. But I like the idea of multiple platforms of vaccines out there, right? Because we know that some people, for instance, the hepatitis B and C vaccines don't work, right? The body doesn't make the antibodies for it. They have to get it again and again, right? I like the idea of multiple platforms. I don't think that changes the herd immunity, because whether you are immune because of X or Y, it's not relevant to the fact that you're immune. I like having the inactivated virus because that's one we all recognize, right? That's the vaccines we're born and raised with. So some people who don't like the current vaccines because they were sped into creation would probably be comfortable with an old world style of vaccine, an inactivated virus. I think that's good. Plus, overall, right, and we both come from a health IT perspective, multiple platforms in play at the same time breeds innovation. One is going to win because it's going to be better. And that by making it better, I'm very excited about gene therapy-based mRNA type of vaccines and medications going forward.
Yeah, I want to add to that, Ajay, and that is, out of all these, I think mRNA is the first time, even though that technology first had a lot of doubters.
Yes.
And, it's actually the first test by fire, right, of this particular platform, because it wasn't used before up until now. Even though it's been around, there was a lot of doubters, a lot of naysayers, just because they wanted to have the true and proven platforms. And I agree with you. I think that the more platforms that we have, the more the more innovation there is. And I would say that this is one of the silver linings is the fact that now, mRNA is, has gotten its trial by fire of just, saying, yes, we got it. And they were the first ones. Oh, and by the way, they have the highest efficacy compared to all the other platforms, at least based on what we know so far. And, I think that's actually a great thing. I think that would love to see this approach in, whatever else is going to be the next pandemic, to see what additional platforms come out. And I think that all of this will be, just a chance for pharmaceutical companies and others to actually become better at innovating.
Yeah, I saw that you put the note that pharmaceutical companies need to be transparent with their business model. Yes, that'd be great. But I certainly do want them to be more innovative and cure more disease. I mean, one of the things we're also seeing clinically is that, and this is not unexpected whenever you have a novel disease, that the rate of secondary bacterial infections is rising. And the primary mechanism of treating secondary bacterial infections is broad spectrum antibiotics, which is good for the patient in the moment, but does tend towards increased antibiotic resistance of those underlying bacteria in the long term. That's a problem. So we are working with providers and pharmaceuticals to anticipate the secondary bacterial infections as well as their antimicrobial resistance levels so that health systems can target treatment versus broad spectrum treatment and lower the risks of bacterial immunity to our countermeasures of antibiotics.
Bacterial, that could be the source of the next COVID type academic.
Absolutely. Viral, bacterial, fungal, any of them can cause an endemic and pandemic disease. Any emerging vector of disease. Yeah.
Yep. Are there any other questions from the audience? And if not, I'd like to find out if you have any song requests for Ajay.
Yeah.
You did promise that, right?
Anytime. I'd love to. So Nancy has had the privilege or the pain of hearing me sing in the past, so maybe you've got a song you'd like.
I don't know. You're welcome to sing, but I have not had nearly enough to drink to participate.
So I just want to thank Ajay for this great talk and also the demo. And I think he's already shared his contact information via the chat. I want to also thank all the audience for attending. You'll be getting a link of today's session post-event page with all the information that I discussed earlier, announcements in addition to the bulk of today's talk and demo. And if you have any other questions, it'll also have a way for you to contact Ajay or myself if in case you have any additional questions. And also, one of the things I forgot to mention is we actually have a sponsored talk next month in May, our next meetup. It's actually going to be done on hyper automation and the use of hyper automation to improve business efficiency by improving business processes. And that's going to be a company called Mind Over Machines. They just announced and provided me the material. I just created today the meetup page for May, so it's already in our meetup. So I hope that many of you will come back and continue to see some of the material that we've been bringing in, just to make sure that we have these discussions about, new science, new platforms, and kind of like this convergence of analytics to kind of focus on ways to improve not just businesses, but actually our lives as well by, different applications that are out there, companies that are using analytics to make better decisions at the right time for whether it's for saving lives or for actually improving the performance of organizations. So I want to thank the audience once again, and thank you, Ajay, for this. And I guess we can actually also wait for requests and we can hang out a few minutes more, but just in case anybody has to drop off, I wanted to make sure that we would do the closing. So thank you so much.
Yeah, beat it. That's a great idea, Valerie.
That's a good idea.
We have got to, do you got the music for that? Let's do it. Let's do Beat It. I'm sure I've got it on YouTube. I'm going to look it up.
I'm sure there's a karaoke version with the lyrics also.
So I think, Valerie, we can add that to the agenda for hymns this year, right? A karaoke session. That would go along well. Be well received.
Yeah.
Oh, yeah.
Yeah. Got it, right? It's on YouTube.
Yep. So if you can share the sound, so share your screen and then share. Make sure you click on share the sound under more. You'll see that come up. Once you click on share the application,
I don't think that I can do.
Those emotions.
We can hear it.
They were put
Or-
on hold by
Can you hear
time,
this?
by careers being built.
All right, let's try it.
But at Claire's bridal,
All right, we're gonna try. We're gonna do karaoke. Beat it. All right, everybody knows this song, so jump in, join me. Big opening. This is earlier. Michael Jackson's pretty high-pitched voice on this one, right? Children, don't you ever come around here. If you wanna see your face, you better go here. The fire in your eye and the words are really clear. So beat it. Just beat it. Better run, you better do what you can. You wanna see no one you're not your man. You wanna be tough, better do what you can. So beat it. You wanna be bad, just beat it. Beat it. No one wants to be defeated. Show them how country strong as your back. It doesn't matter who's right or wrong, just beat it. You take the vaccine and beat COVID-19. Great suggestion, Valerie. That was fun.
All right. Thanks so much, Ajay.
Okay.
And thanks everyone for joining us. Reach out if you have any other questions, comments. We'll be sending a follow-up email, and then it'll have the information that you need to view the post-event page. And once again, Ajay, thanks so much for a great discussion.
My pleasure. Good to be with you guys, everybody.
All right.
Thanks.
Have a great weekend. Happy Easter, everyone.
Be
You
easy.
too.
Thanks. Same to you.